Welcome to Eldercare Illuminated, Torchlight's caregiving podcast. Eldercare Illuminated addresses the ins and outs and ups and downs of caring for your loved ones. Join us for interesting conversations with eldercare specialists, geriatric care managers, attorneys, and ordinary people with extraordinary caregiving experiences.
Welcome, listeners. I'm Lenore Tracy, Torchlight's Eldercare Practice Leader and host of the Eldercare Illuminated podcast. In the course of my work, I get to talk to a lot of people who are taking care of someone they love, whose health is deteriorating, and who are facing end of life in the foreseeable future. For many, this is a scary time, and a time when people's personal beliefs are called into question. Families and patients often want different things, and misinformation can create painful conflicts. One of the most helpful resources that families can rely upon to help sort things out and to be there throughout the period preceding and actually during and after a loved one's death is hospice. But in my experience, there's lots of confusion about what hospice is and what hospice isn't. I've invited friend and colleague Beth Rubio, who is a hospice social worker, to join me today to talk about hospice. Beth is a licensed social worker and has worked in the hospice field since the early 1990s. And truth in advertising, Beth was part of the team that worked with my family when my mother was dying. Thanks for being with us today, Beth. I'm so grateful to be able to share some of your knowledge and wisdom with caregivers who are struggling with or anticipating the death of a loved one.
Thank you for having me today. I've been looking forward to seeing you and actually getting to share a little bit about what I know and what I think might be helpful for some of your listeners.
Excellent. There is so much I'd like you to cover. It's hard to know where to begin. But I think we should start by asking you to dispel some of the myths about hospice. Many people think that hospice is a service provided in a facility for patients, usually patients with cancer who are nearing death, by which I mean very close to actively dying. Tell us what's wrong with that concept.
Well, the perception that people have to be actively dying to enjoy and experience the hospice team early on in the process is really what you say, a myth. Hospice is a process. Many people come on hospice way too late to enjoy all the benefits of the team. One of the things that people do think often is that a cancer diagnosis is necessary for hospice. The most successful hospice journeys are for patients who have long-term chronic issues like congestive heart failure or COPD, cardiac health issues, even advanced dementia, who are able to come on early enough where the team can get to know the family. Early enough can be 6 months to 2 years. We have patients that come on who have just been declining over time. You get to see the fact that someone who has chronic lung problems, well, they used to go out shopping every 2 weeks. Now they're going once a month. Now they don't like to go in the car. Just subtle changes in somebody's functional abilities makes us acutely aware that the disease is progressing, however slowly, and they do meet the criteria for hospice. And many people don't think about a subtle change as an indicator of hospice.
Let me back you up just a little bit because you've mentioned a couple times the team, and I'm not sure that our listeners know that you get a whole package of resources with hospice. They may just think it's a nurse and not even know. I'm talking to a social worker here that you get a social worker. So tell us what the team typically looks like.
So maybe I could use a good example of an experience.
Perfect.
My dad passed away a little over 10 years ago, and he was visiting me. He lived on the Cape, he and my mom, and he was visiting me and ended up unexpectedly at a acute care hospital with just an infection, but nothing big. Nobody knew what was truly going on. And he was discharged in 2 days. And I asked the hospital at that time to make a hospice referral. And they felt that, there's nothing wrong with him. I said, he has just been diagnosed with congestive heart failure last year, and I have seen him decline. And I'm asking the hospital to put the referral in place. And if he is eligible, I'd like it to start sooner than later. And fortunately, the hospice team came in down the Cape and did see that he met criteria. And he was on hospice for about 8 or 9 months, and he passed. But his team consisted of a social worker to support my mom, a hospice nurse, a hospice aide, a chaplain that would come and visit both my dad and mom. And one of the most valuable pieces for my mom was a hospice volunteer who came. And my father liked to play cribbage. My mother hated the game. And that was something they got to do together once a week. It gave my mom a little break. It gave my father, who couldn't go out any longer to play cribbage, an opportunity to establish a relationship over 8 months with his volunteer. So when we talk about the team, we talk about the accessibility of staff 24 hours a day, 7 days a week is a huge relief for families, particularly in my mom's case, knowing that she could call someone anytime if something didn't look right with my dad, or something, she had a question, or she wanted to go to the hairdresser and wanted to sort of talk about not leaving my dad alone, and could we schedule an aide around that time, or could it be when the volunteer came? So we truly talk about a collaborative effort. My particular hospice, I would say, goes a little bit above and beyond because we are a more holistic hospice, and we do have licensed music therapists who join our team as well and provide music therapy, as well as volunteers that do Reiki. It's just an additional thing that we believe is a bonus at end of life, to sort of incorporate music, which is often sort of hearing and staying connected with people as they continue on their journey. Hearing and music is always a major neutralizer.
I understand hearing is the last sense to go, and so music could be really important. I know for my mother, who was a music lover from her early childhood, it made a tremendous difference, and we had a volunteer who came and did music with her. She had 2 different volunteers. So I think people maybe don't know that the volunteers are a big component of the concept of hospice. My mom was lucky enough to have a young woman who came and played the guitar and sang. So she had live music. Mm-hmm. And then she had another woman who loved opera the way she did. She loved all kinds of music, but my mom especially liked opera. So she was lucky enough to have that all the way through to the end. And, based on what you said, it's obvious that the support is not just for the person who is dying, but for the whole family who's undergoing this giant transition. How would a family know when it's appropriate to bring hospice in? You've got special skills, mm-hmm. so you could speak up about your own father. How does somebody, and I'm going to also especially point out patients with dementia, and there are more and more of them, and most families don't, I think about hospice for end of life for a dementia patient. How does a family know when it's a good idea to bring hospice in, and then how do they do that?
I'm glad you brought that up, because historically the primary diagnosis for coming on to hospice has been cancer, and the expectation is within the next 3 years the primary diagnosis will be dementia. The difference with dementia is we need to think about that person's daily life, because when you're living it, it's hard to look and see decline. When you get an objective person like myself or a nurse who comes out and can say to you, well, 6 months ago, was this person able to go to the bathroom on their own? 6 months ago, was this person able to eat a full meal? And there are specific changes that we see with someone with advancing dementia that makes them eligible for hospice. And it takes a skilled professional to ask the right questions. You might have all the answers, but not be able to put the puzzle together. So one of the best places is when you are at your doctor's office to ask, is my mom eligible, or dad or my husband eligible for hospice, or at least could we talk to someone about it? And sometimes the physicians get into a a cone themselves where the electrolytes are balanced, everything is still coming out, but they don't see the big picture. They've lost 6 pounds. They can't get in and out of the car anymore. They're sleeping more. All of these things are indicators that the disease is beginning to progress to a point where function is changing, and functional changes are very prominent in getting someone onto hospice, particularly around eating, activities of daily living, and just bowels and bladder. If those things have changed, it's an indicator that the disease has progressed and there's a high probability someone might be eligible.
I remember talking with my mom's primary care physician when she was in the later stages of Alzheimer's, and we were having a discussion about hospice, and I asked about that criterion about dying within 6 months. And this physician, who she was wonderful, we loved her, she said, nobody can predict when somebody's going to die. This is her voice, she said, I'm not looking at a patient and saying, are they going to die in 6 months? I'm really saying, would I be surprised if this person passed away within the next 6 months? And if the answer is no, I wouldn't be surprised at all, then they're probably appropriate for hospice. And a lot of the things I know that she was looking at were functional. They were not her blood levels and her medical status, but were how she was functioning, sleeping, eating, the kinds of things that you were saying, particularly weight loss. Mm.
So you bring up a good point, because that is often how I phrase the question. The 6 month is a term that needs to be written in order for Medicare and other insurance companies to qualify someone for hospice. But the question is, ultimately, with somebody's comorbidities or prior medical history, would it be surprising or shocking if the person passed in over a 6 month period? And if the answer is no, based on the fact that they have a long-term cardiac history or lung function or poor liver or kidney problems, if the answer is simply it wouldn't be a shock if their chronic health issues contributed to their death within 6 months, then they're simply eligible for hospice. And I think that takes away the fear that they're getting a sentence of 6 months.
Exactly. And I think people need to understand that if you're not thrown off hospice, if you haven't died, you've got a deadline. You've got to die by October 14th or you're out of here. It doesn't work like that. The Medicare, you mentioned Medicare, the Medicare hospice benefit is a wonderful benefit and pays 100% for
Absolutely.
the team care that is given. And the patient is reevaluated every 6 months. But people can be on hospice for as short as a matter of days or as long as a couple of years. I mean, what have you seen in your own experience?
Well, as we know, people's expectations can be one thing, and the patients we take on have their own expectations of what they're going to, how their journey is going to go. Just personally, you have done yeoman's work with your own mom. She had been on service not for 6 months, but much more than 6 months, and she had a determination that was her own goal. So she came on and stayed on service much longer than we all anticipated.
Yeah.
And she was eligible every time we reviewed her because
Absolutely.
There had been declines. The expectation was that we didn't think she would be with us as long as she was, but with that gentle care and the team's effort, she called her own shots. And each time we reviewed her, we were able to certify to Medicare that she is very different than she was the last review, but making her journey at her own course.
And that is another really important point, that good care prolongs life. Sometimes that's a good thing, sometimes it's not a good thing, but when somebody is getting very good care, often it does make a difference in that regard. There's dying and there's actively dying. And so when someone comes on hospice, they're on hospice because they have a terminal illness. And the expectation is it wouldn't be a surprise if this person died within the next 6 months. And I actually should have that statistic, but I don't on the top of my head of the average amount of time that a patient stays on hospice. Can you talk to us about the difference between dying and actively dying? Or if there are better words than that?
So from a practical perspective at hospice, we use 3 terms. We have someone who is routine, and that means that their chronic health issues are being managed by the team, but there's no acute change in their status. And then we have a period of caring for someone, which we call transitioning. So there may be a change in somebody's oral intake, or eating less, or sort of putting out urine a little bit less, or spending more time in bed, or a change in their routine. The nurses generally assess this, and sometimes this could be about a 2-week period, which we call the transitioning period, where we assess the patient that it's highly unlikely there'll be a turnaround of any sort and return back to what we might have called their baseline. And then there's the active phase. So that might be, 2 to 4 days where we expect that the person's may not be alert, may not be engaging, may not be able to take in any fluids, and predominantly we're focusing on comfort and pain management at that time, and particularly educating families on what to expect. I think that's a major part of the job, particularly during transitioning and active, because if you've been with your loved one for such a long time, no matter how much you've been educated and kind of reminded about the process, when it comes up, it still seems to hit you in the face.
So as an expert, I know when we talked to my mom's physician right before she began to get hospice services, that the physician said, no, we can't predict when someone is going to die. But as a hospice worker, it sounds like you are closer to the very subtle changes that are happening with your patients. Pain management, you mentioned, it's really important for families who don't want to see someone that they love suffering. How is pain management part of the hospice program? And are there differences if you're at home or in a facility?
Sure. So that's a great point, because pain management is handled very differently in a nursing home setting than it might be in an assisted living setting, than it might be in a certain person's home, private home. One of the very most challenging places to provide end-of-life care and reasonable pain management is in assisted living, because oftentimes families are not at the bedside in an assisted living, and the staff that care for patients in that environment have limitations on what they're allowed to do and assess. There always seems to need to be a contingency plan, because if someone is in their apartment and having to be monitored and assessed fairly frequently by somebody who's capable of administering pain medication, it isn't something that necessarily comes with a package at assisted living. So that's obviously a great role for social work, is to figure out how we can best use resources and expectations in that environment to try to keep that person in their apartment while maintaining vigilance on pain management.
So how would you do that? What can you put together?
So one of the things is working closely with the assisted living staff. Occasionally, we will have our own aide in there for blocks of time. Frequently, the social worker works with the family on trying to either have the family stay in the apartment in shifts, or hire private care aides that are authorized and capable of administering medications based on what the hospice nurse recommends. Mm-hmm. I've had situations where families want to sleep over at the assisted living and be that person, but also I've had situations where they, have hired someone from 7 p.m. at night to 7 a.m. at night for the final couple of weeks or days, because they want to spend their time with the person during the day and not be awake all night, assessing and checking things. In a nursing home environment, there are nurses there 24/7, and the nurses are consulting with our nurses about symptom management, and we know we can stay on top of it. In the home environment, we are counting on the family to accept the recommendations and begin to feel comfortable with administering medications, particularly sometimes pain medications that have been perceived as frightening in the past, to help keep the person comfortable. So in the home, we have the tools, but the tool of the nurse is to get the family and caregivers on board with understanding this is a shift, and now we're managing the patient in this way.
I think it's important that you mention that scary factor. So my mom was at home during her whole hospice experience, and she was able to die at home, which was what she had wished for. And we did do pain management at home, and it was very scary for me. The first time I'm administering morphine in this case, and it's like, how can I be doing this? I'm giving my mom morphine. It's a little bit scary. On the other hand, I can't bear to see her in pain. I got used to it. I also learned from one of the aides who was with her routinely, was with her for a very long time, and for whom I am eternally grateful. And she was able to say to me, your mom is in pain. My mom was not vocalizing. She could no longer say, I'm in pain, and she wasn't, moaning or crying. But this aide could say, look at your mother's face. All of a sudden, her face is not relaxed. She's grimacing. She's tensed up. I think she's in pain. That was a huge thing to learn. And you guys recognize pain when family members don't, oftentimes. How do you approach that with a family who's not seeing that their loved one, whom they don't want to be suffering, is?
Right, good point. I mean, I think you also need to remember who you're talking to. So if your caregiver is a son who's an engineer, for example, the team is going to speak to that caregiver in a language that they understand, in as far as symptoms, respirations, meaning are they breathing faster? Let's teach you how to count how many breaths in a minute, and recognize that sometimes rapid breathing is a symptom of pain when you can't verbalize it. The furrowed brow that you were speaking of, and the facial grimacing. An elevated heart rate, meaning you just simply, if the heart is beating faster, that can indicate pain. Sometimes we see what we call contractures, or hands tightening up, or the body's kind of curling up a little bit. Or even simply when you touch someone gently and you hear moaning. I mean, these are things that we use as a nonverbal pain scale that we try to teach family members. One of the things we work hard at is trying to do something called staying ahead of the pain. And we help educate families on the value of getting medications on consistently particularly during transitioning and active portions of the journey, so that we don't have patients suffer from what we call peaks and valleys. We want to make sure patients have enough pain meds inside of their system so they're not having periods of furrowed brow or grimacing. And I think this is the challenge for caregivers and family members, because they want to have a sense of presence with their loved one and feel like there's still a connection, whether it's through eye contact, verbally. But there's also a balance of making sure people might be more sleepy or less alert, but far more comfortable than if they were able to sort of make simple sounds or look at something or squeeze somebody's hand that's meaningful to the caregiver, but it might put the loved one, the patient, in jeopardy of having some discomfort. So a lot of those conversations are things that we as social workers and nurses are trained to do to help families make that crossover.
I'm thinking about that in the context of my own personal experience, which was with someone who eventually became completely nonverbal. You must have worked with many patients who were cognitively intact up until the end. So where's the patient in all this? When do they get to talk, and how does that typically work? If you have someone who doesn't have, any cognitive issues happening, but they are with it.
Correct, yeah.
The whole time. So how does that go?
So oftentimes, they may have expressed numerous times that they would want to make sure they were comfortable. It's a common theme. I want to be comfortable. I don't want any pain. Make sure I'm comfortable. So patients are very receptive, particularly to pain management towards that portion of their life because they're scared. And I think if people are alert and aware of what's happening, it can be frightening and isolating. And what we also see is something called terminal agitation and anxiety. So someone who may not have been particularly anxious is very restless and almost appears like they're crawling out of their skin. Our job is to make sure that we read those cues and understand that the person can't really make a decision about their symptoms. These symptoms are coming fast and furious, and they're counting on us to manage them. So we may continue to medicate someone, and they may eventually sort of slip into a position where they're less able to communicate, but we need to respect the fact that this is what they asked for. Mm-hmm. They didn't want to be afraid. They didn't want to be awake at all costs and then sort of struggling with the physical pain and the emotional pain of, being stuck in the middle.
Yeah, it's scary for everybody
Absolutely
involved. Death is not part of our lives on a routine basis the way it was in the 19th and early 20th century. People do not routinely see their loved ones age and die, or as in earlier years, get infections, young people, and women dying in childbirth. So it's foreign territory, and that's one of the things that hospice can help with. It was clear in my personal experience, but also from what you're saying, you're educating the whole time.
Absolutely.
You're a teacher as well as a supporter. Are there things from the hospicist perspective that family members can do to make the time that someone they love is on hospice better? Or conversely, are there things that families should avoid at all cost during this time to make the experience better for everybody?
Mm-hmm. The number one thing I would say is when families are considering having someone be cared for at home, particularly, or in assisted living, which requires a larger input from family members to manage in those two settings, is be realistic about expectations of other family members. I think one of the main themes that comes up is that there may be one primary caregiver who expects that everyone will be on the same page about this person's passing and what this person's needs will be. Not everyone is cut out for bedside support. And the sooner people recognize that this is the piece that they can do in the puzzle, the less angst there will be in the family and with the patient. Because if there's one person who's capable of doing bedside care, but the other person can make phone calls and can't provide personal care or doesn't feel comfortable giving medications or can't commit because of a work schedule, that is the thing that is helpful to sort of tease out in the beginning. Because then as the patient's needs increase, the expectations aren't correct. The fact that you expected somebody to take a leave from work, or you expected somebody to be here on weekends, or particularly, say there's a caregiver in the group that's a nurse and you expected the nurse to rise to the occasion. I think one of the things that social workers do right away is assess the resources and the ability of the non-professional caregivers to add to the team and help come to terms with the fact that people have limitations.
It's hard to accept our own limitations and hard to accept other people's frequently, but I think kind of the ability for families to suss out the different roles for people, that sounds important also for the whole experience. And when you're looking back on it, guilt is such a giant part of caregiving, unfortunately. Caregivers often, they feel guilty for what they are doing. They feel guilty for what they're not doing. They feel guilty for being angry with their loved one or with their siblings or with their kids. There's a lot of guilt and anger. And you're suggesting a pathway, which would be to figure out, well, you're the person who does all the telephone work. That's your job, and you can do it, and you'll do well at it. Do you actually articulate these things and kind of get it out there on the table? Because To me, it sounds like different family members, different strengths and weaknesses, they could embrace their strength and let go a little bit of what they're not doing. So they're not able to do personal care. That's okay. They're doing all the, ordering supplies.
Mm-hmm. So I think in the social work profession, we often pull together families and have sort of what I would call in the Christian world, a coming to Jesus meeting. This is the reality of the situation. This is what we're faced with. And I'm thinking recently I had a family meeting where there were 5 siblings and we met, and one clearly was the predominant caregiver. She didn't work full-time. She had a small part-time job, and the other siblings were married and had families. And when the expectation was presented that this person would stay at home, and this is what we needed to keep the person home, and the other family members were very clear and said, I cannot commit. I can bring a lasagna over twice a week is what I'm willing to commit to. It was hurtful to the person who was spending the most of the time. But it was necessary for me to sit down and help everybody recognize that you can't wish and have magical thinking that people are going to alter their lives to what you believe is best for your loved one. Not everyone's cut out for it. And I think we also need to remember caring for somebody isn't natural, particularly if you had an adverse relationship with them along the way. And if you're expecting somebody who may have been physically abusive to you or may have neglected you over time or may have had a restraining order against you at some point in your life, and now you're asked to sort of step up and care for that person, there is a lot of background there. So that's where the skilled social work piece comes in to help people realistically tease out how we would manage. Maybe for the cost of having a private caregiver and knowing you can drop by twice a week, it doesn't matter if you don't have a full-time job. This is what you're capable of adding to the equation. And it doesn't necessarily mean that just because you're bringing somebody home, everybody's lives stop.
Was that family ever able to get to the other side of this?
Somewhat. We brought in private help, and 2 of the 5 ended up coming and committing it. Interestingly, it was the sons and not the daughters. Yeah. And usually it's the opposite, but the 2 of the 3 daughters were very clear about what they were willing to do. And it wasn't necessary for anyone to bully them or put them into a position where they felt guilted into doing it. And there was some amount of respect for the fact that they set their limits.
I think that's important to understand your limits and to accept them. And that reminds me that hospice care doesn't stop when the person is pronounced dead, because there's all the feelings that come afterwards. So that your loved one has died, the hospice equipment is removed, and if your loved one is dying at home and hospice service is at home, there may be a lot of equipment. There may be a hospital bed and oxygen and who knows whatever else that was supporting that person. All of the hubbub subsides, and everybody is left with their feelings of sadness or guilt, their review of, well, how did this go? And hospice is still there.
Absolutely. So, as we're sitting here together.
Yeah. What's the typical scenario after the person who's getting the hospice, the center of this whole show is gone? What does hospice provide?
So hospice provides 13 months of what we call bereavement support after the person passes. And the 13 months is important because we try to make sure we're there and available for the anniversary, the first year anniversary, which can always be difficult. One of the things we do at the time of a person's passing is assess the families for a bereavement risk scale. So there are some people we put at high, moderate, or low for bereavement, and either a social worker or the chaplain will continue to monitor that situation. I'm thinking years and years ago, I had an interesting situation where a patient had been living in an Alzheimer's unit on a nursing home, and his wife had visited daily, and he was on hospice, and his children were saddened by how much time that the wife had spent with the husband at the nursing home and how many things they felt they missed out on based on the fact they had their own kids and she was a grandmother and she chose to stay at the nursing home rather than go to some of the events for the grandchildren. And he passed, and unfortunately a week later she passed very unexpectedly.
Oh my.
Yes. And I made several visits to the adult children after because they were stuck with frustration because this was going to be their time to show off their grandchildren, their children to their mom. And they were waiting and waiting to have her back. So it goes to show bereavement isn't necessarily initially for the person who may have been your patient, but for other scenarios that come up and make it more complicated to move forward.
Well, that sounds really, really hard to resolve.
Right.
And now they've lost both parents. Beth, thank you so much for spending time with me today. I know how much all the members of the hospice team helped my family when my mother was dying. And you've sorted a lot of fact from fiction in today's conversation for other families who may be seeing this ahead of them. It is a huge benefit to be able to have a team to teach you and on whom you can rely to get you through the scary parts and the sad parts. Caregivers, your understanding and knowledge about living and dying well makes such a difference in the lives of the people you love. Take care of yourselves and be well, and we'll see you on the next episode of Torchlight's Eldercare Illuminated. Beth, thank you.
Thank you for asking me. I've really enjoyed being here today.
Thanks for listening to Eldercare Illuminated, a Torchlight caregiving podcast. Find other episodes of Eldercare Illuminated on iTunes, Spreaker, and Podcast Go. If you're interested in bringing Torchlight Elder or any of Torchlight's other caregiving products to your workplace, please contact info@torchlight.care. That's info@torchlight.care.